Good afternoon, everybody. Let's start the afternoon session before the validatory function. Can I ask Dr. Madhavan to come on dais? Dr. Aravinda, Dr. Mohan Rao.
Good afternoon. I thank the organizers. I'm a sudden inclusion to chair this session. I was not part of this originally. So we have very important topics in this session on autonomic dysfunction, precision diabetes care, and cross-link between diabetes and anemia. The first talk will be by Dr. J.K. Sharma on autonomic dysfunction in diabetes. You know that autonomic dysfunction is very, very important part of diabetic neuropathy. Can result in so many problems unless we are properly examining the autonomic function in diabetic patients. So we are going to hear from Dr. Sharma about what are the autonomic dysfunctions in diabetes. Dr. Sharma.
Good afternoon to all, and my heartfelt thanks to the all organization here also. All organizers of this 15th annual conference of the RSSDI Tamil Nadu chapter. Special thanks to one and all. So in the next 15 minutes, the job assigned to me is to talk about the autonomic dysfunction in diabetes. We all know that diabetic autonomic neuropathy, that has been defined as a disorder in the autonomic nervous system in the setting of diabetes mellitus or metabolic derangements of pre-diabetes after exclusion of the other causes. So exclude the other causes and then in a diabetic or a pre-diabetic setup look for the autonomic dysfunction. The various essential points regarding this diabetic autonomic neuropathy, it involves dysfunction in the autonomic nerves impacting the bodily functions, and the severity varies from being asymptomatic to causing noticeable symptoms, making early diagnosis very challenging. Patient may come with a very vague symptom, and this is significantly associated with increased morbidity and mortality, particularly due to its association with the cardiovascular complications like the cardiovascular autonomic neuropathy. And it may coexist with other diabetic complications, which again complicates the management. We have read and learned about the sympathetic nervous system, the parasympathetic nervous system, and the enteric nervous system, and the famous fight or flight system originating from the spinal cord is the sympathetic nervous system, and the rest and digest system, which is arising from the cranial nerves and the sacral spinal cord, that is the parasympathetic, and the enteric nervous system that governs the function of the gastrointestinal system, and that is independent. The pathways, these preganglionic neurons and the postganglionic neurons, the preganglionic neurons, they originate in the central nervous system and project to the autonomic ganglia, and from the autonomic ganglia, they extend from this to the target organs, allowing for modulation of the functions. And when we talk of the functions of the autonomic nervous system, sympathetic functions, they increase the heart rate, they dilate the airways and mobilizes the energy during stress. The parasympathetic, they decrease the heart rate, they stimulate digestion and promote restoration during non-stressful conditions. And the homeostasis maintenance is continuously monitors and adjusts the bodily functions to maintain stable internal condition of the person. Prevalence is 20 to 90%. Individuals with diabetes, they may exhibit signs of autonomic dysfunction, and 20 to 50% prevalence of cardiovascular autonomic neuropathy in type 2 diabetes. So it is a very, very important and high prevalence of this scan, and up to 90% prevalence of cardiovascular autonomic neuropathy in long-standing type 1 diabetes patients. Risk factors: duration of diabetes, longer duration, poor glycemic control. The glycemic control remains the mainstay, which we'll see in our further presentation also, that even in the management of this autonomic neuropathy, problems, dysfunction, the glycemic control remains the mainstay of the treatment. Because the poor glycemic control, then the comorbid conditions like the obesity or the diabetes, hypertension, dyslipidemia, and other diabetic complications. Severity of diabetic autonomic neuropathy is associated with increased cardiovascular morbidity and mortality, and the onset is subclinical form can appear within 1 to 2 years of the diabetes diagnosis. I have told you about this, the diabetes duration, glycemic control, obesity, and the hypertension. Very important, look at the 4 pathophysiologies: chronic hyperglycemia, which leads to metabolic disturbances and the nerve damage; oxidative stress, increased reactive oxygen species damage the nerve cells; hyperglycemia triggers inflammatory pathways, further contributing to the nerve injury; and the neuropathy mechanism, axonal degeneration, damage to the nerve axon, impair the signal transmission; demyelination, there is loss of myelin sheath, lead to the slower conduction velocities, and the microvascular complications, diabetes-related vascular damage, affect the nerve blood supply. And the insulin resistance, of course, which impairs the glucose uptake in the peripheral tissues, contributing to the neuronal damage. The clinical manifestations of diabetic autonomic neuropathy we can divide into the cardiovascular, the gastrointestinal, genitourinary, metabolic, pseudomotor manifestations, and the pupillary manifestations, which I will discuss further. And very important is the differential diagnosis of diabetic autonomic neuropathy. Pure autonomic failure, multiple system atrophy with autonomic failure, the Side-Drager syndrome. Then the neuropathies, the peripheral autonomic neuropathies, such as amyloid neuropathy and the idiopathic autonomic neuropathy. Then the certain medications like the anticholinergic or the sympatholytic effect from insulin, vasodilators, and the sympathetic blockers, Addison's disease, hypopituitarism, then the pheochromocytoma, and of course hypovolemia. So they should be considered as the differential diagnosis. Cardiovascular manifestations, very important is the resting tachycardia, elevated resting heart rate often between 90 to 100 beats per minute. Then exercise intolerance, reduced ability to tolerate physical activities, early fatigue. Patient complains that he becomes exhausted even with simple slight walking due to impaired cardiovascular response to the exercise. Then very important is the orthostatic hypotension, dizziness or fainting upon standing due to inadequate blood pressure regulation, and especially in elderly populations, especially when there is long-standing diabetes, this should be taken into consideration. And at least in our clinical practice, we all physicians must check the blood pressure of our diabetic patients, especially who are above the age of 60 years, by lying down, sitting, and standing posture always. Silent myocardial ischemia, lack of typical symptoms during heart ischemia, increasing risk of heart disease. So take the history, proper examination, and whenever required, a electrocardiogram of the person. There are various tests which we can perform to look for the cardiovascular autonomic testing, and they are the parasympathetic test where the heart rate variability, heart rate response to standing, and Valsalva maneuver. In sympathetic, we look for the blood pressure response to Valsalva, the tilt table test, and the hand grip dynamometer, and the cardiac autonomic imaging, also direct assessment of the cardiac autonomic integrity using the scintigraphic imaging. And this is, you can see that we regularly do in our clinic for all our diabetic patients. We look for the resting heart rate, the standing, deep breathing with standing, and the Valsalva to look for the parasympathetic system. And for the sympathetic, there is postural hypotension and the sustained hand grip, and this is what we do in all our patients at least once in a year. Coming to the management, as I told you earlier, glycemic control remains the mainstay of the treatment. Continuous glucose monitoring helps stabilize blood sugar levels and mitigate diabetic autonomic neuropathy symptoms. And Dr. Jyoti Dev has explained in his oration detail about this continuous glucose monitoring. Newer anti-hyperglycemic agents like the GLP-1 receptor agonist and the SGLT2 inhibitors, they provide cardiovascular benefits. And intensive glycemic management, again, slows the progression of neuropathy and reduces the cardiovascular risk. Blood pressure control, ACE inhibitors help manage hypertension and improve the autonomic function, and lipid management, statins, they reduce the cardiovascular events and improve the overall outcome of the person. Orthostatic hypotension managed with fluid intake, compression, stockings and medications, and especially look for if the patient has hypovolemia. If an elderly person is taking SGLT2 inhibitors, of course we have to look for that there is no orthostatic hypotension, and once we should give the tailored exercise program, and they improve the cardiovascular fitness at the manage the symptoms of this. Lifestyle modification always remains dietary intervention. Heart healthy diet can improve metabolic control and reduce the cardiovascular risk. Smoking cessation and alcohol reduction addresses these factors for the cardiovascular disease. And then regular monitoring. Cardiovascular autonomic reflex tests like identify early signs of DEN for the timely interventions. The other emerging therapies like the antioxidants, alpha-lipoic acid shows promise in reversing the diabetic neuropathy, and advanced glycation end products inhibitors may provide new treatment avenues in the future. Gastrointestinal manifestations. Diabetic patients coming with diarrhea, coming with constipation, irregular bowel habits. So esophageal dysmotility, difficulty in swallowing and esophageal movement. Gastroparesis, delayed gastric emptying leading to nausea, vomiting and the erratic glucose control. Constipation and diarrhea, reduced or increased bowel motility or sometimes alternating. And then fecal incontinence, loss of control over the bowel movements, which is again very important and troubling to the patient and the family. The various effects of diabetes and the motility of the various parts of gastrointestinal tract, you can see at the level of the esophagus, there is reduced esophageal mobility, reduced fundal relaxation, early satiety and dyspnea, delayed gastric emptying, gastroparesis, nausea and vomiting, and at the intestinal level, decreased or increased intestinal transit time leading to diarrhea, increased colonic transit time, constipation and changes in the microbiota leading to diarrhea, and microbiota in health and in diabetes in itself is a large topic to be discussed. Gastric emptying, scintigraphy and isotope basal breath tests are very important in diagnosing gastrointestinal autonomic neuropathy, and then the anorectal manometry to evaluate the sphincter tone. So if any patient comes with these symptoms, we must take opinion of a gastroenterologist, but before that, please write your full note, what you are expecting. Whether you are expecting the gastrointestinal autonomic dysfunction in this patient or not, because the other person, the gastroenterologist, may be busy and he may not look for this. Management, again, glycemic control and then the pharmacological interventions. The prokinetic agents, medication like the metoclopramide or the domperidone, they enhance gastric motility and alleviate symptoms of gastroparesis. Antidiarrheal medications, loperamide, that may be used to manage diarrhea's episode effectively, and laxatives for constipation management. Osmotic laxative or stimulant laxative can be prescribed based on the patient's need. Prokinetic agents, antidiarrheals and laxative manage the GI symptoms. Dietary and lifestyle modification, of course, small frequent meals and the physical activity. Multidisciplinary approach is there in managing these patients: endocrinologists, the gastroenterologists, dietitian and the diabetes educators. Now another very, very important is the genitourinary manifestations, neurogenic bladder dysfunction and bladder control leading to urinary retention or the incontinence. Erectile dysfunction, difficulty in achieving or maintaining an erection in men, retrograde ejaculation, female sexual dysfunction. And please make it sure to ask the patient regarding this, because patient may feel shy, he or she may not come out with that, these symptoms may be because of diabetes. So we have to ask every patient in confidence, privately, keeping this in mind that this is very, very personal to the patient, to the couple regarding these genitourinary manifestations. Then urologic autonomic function testing by bladder function, post-void residual urine. Post-void residual urine is very important, and it is easy to be done by an ultrasound and the urodynamic studies wherever we think possible, and look for the measurement of nocturnal penile tumescence and penile brachial pressure index that can be seen. Management, again, glycemic control and the pharmacological interventions by the anticholinergic medications. Alpha blockers like tamsulosin can be beneficial for men. experiencing urinary retention due to bladder outlet obstruction, and the phosphodiesterase type 5 inhibitors like sildenafil or tadalafil, they are commonly used to treat the erectile dysfunction by enhancing the blood flow to the penis. Non-pharmacological approaches, pelvic floor exercises, and the behavioral therapy like the techniques like bladder training can help manage the overactive bladder symptoms, but take the help of a urologist. Lifestyle modification, of course, dietary changes, and the hydration management. And it is again a multidisciplinary care, collaborative approach, regular follow-up, and the other emerging therapies are neuromodulator techniques like the sacral nerve stimulation shows promise for patients with severe bladder dysfunction, unresponsive to conventional treatment, and gene therapy. Pupillary manifestations, pupillomotor function impairment, abnormalities in the pupil response such as decreased diameter of the dark adapted pupil, and very common condition is the Argyll-Robertson pupil, where a specific type of pupillary reaction where the pupil constricts during accommodation but not in response to light, and that also we have to look for. Pupillometry, but they are to be done by the ophthalmologist. Management again, glycemic control, patient education, symptomatic treatment, monitoring and screening, and the multidisciplinary approach. So all these problems related to diabetic autonomic neuropathy, if it is not in our mind, we are not able to diagnose and we are not able to manage to the patients. And of course, hypoglycemia unawareness, which is again a very important, reduced ability to recognize low blood sugar levels, and hypoglycemia associated autonomic failure, where there is impaired autonomic response during hypoglycemia episodes, anhydrosis and heat tolerance, and the gustatory sweating, which is the most common symptom patient can come, that even while sitting in the air condition, when he takes the meals, there is gustatory sweating. So this is also because of the autonomic dysfunction. Again, glycemic control, dyslipidemia management. Sir, half a minute more. Only half a minute. Then weight management and the nutritional interventions and the pseudomotor management like the glycemic control and the skin care of the patient. Pharmacological interventions like topical treatment and anticholinergics, and lifestyle modification, again, adequate hydration and avoiding heat exposure. Education, patient education, regular monitoring. So with that, I leave it all to you for any questions, but before I leave the podium, I have already requested you all again to please get yourself registered and come to Delhi on 14th to 17th of November for this mega event. And as I already told in the morning, our senior colleagues of the age 70 and above, they will be registered complimentary. They have to make their own stay and travel arrangements. And below the age of 35 years, those who are interested, those diabetologists, if they are sending their abstract, if their abstract is accepted, free registration, and 100 to 200 people will give the travel grant from the Tamil Nadu RSSDI chapter from Tamil Nadu, and we will make their stay arrangements there. Thank you very much.
Thank you, sir. Thank you, Dr. Sharma, for your mind-blowing and eye-opening message. So it is a dysfunction caused due to impairment of this autonomic nervous system. It is a spectrum of disease. So spectrum of manifestations including all what you have said, including all organs, all systems like cardiovascular, gastrointestinal, pseudomotor, and so on. So thank you for that presentation.
Thank you, sir.
So I think the other queries can be asked at the end of this session. So we'll move on to the second session.
Yeah, good afternoon. It's a very interesting topic. It's a clinical subject. It's a clinical practice, precision diabetes care in clinical practice by Dr. Ranjit Unnikrishnan. Welcome, sir.
Good afternoon to all of you. At the outset, let me thank the organizers of TRACK 2024 for giving me this opportunity to address you this afternoon on a very interesting topic. That is how you will apply precision medicine to diabetes care. I have no conflicts of interest relevant to this particular topic. So what do we mean by precision medicine? To put it very simply, it's providing the right therapy for the right patient at the right time. And it's not a new concept. We have been applying precision approach to medicine since time immemorial. The classical example being blood transfusion. We don't give the same blood to each and every patient. We find out the patient characteristic with respect to the blood group and then give the sort of blood which suits that particular patient. So why is it that now the concept of precision medicine has gained great importance? And the main reason for that being, number one, we now have tools to better delineate the characteristics of our patients. Tools in the sense, biochemical tools, pathophysiological tools, as well as genetic tools to better characterize the various phenotypes and genotypes of a patient. And number two, we also have the tools to integrate all the data we get from using these earlier tools so as to subdivide our patients into categories which may differ in the response to treatment. So that's why precision medicine has now become more important in our clinical practice. Often we talk about the concept of personalized medicine. How does this differ from precision medicine? Again, to put it simply, precision medicine is the science and the personalized medicine is the art. Personalized medicine is nothing but precision medicine, which also takes into consideration the patient preferences and the social context of the patient. For example, a drug A may be the best choice by science for a patient B. But if patient B cannot afford the drug or for some reason does not want to take the drug, or that particular drug is not available in the place where patient B resides, then we'll have to give him something else which is not as ideal from a scientific point of view, but which is ideal from that patient's point of view. That's called personalized medicine. But in my talk today, I will focus mainly on the science part of it, that is the precision medicine. So how does it apply to diabetes? Around 4 years ago, the American Diabetes Association, moving on from a position statement which was edited by Professor Matthew Riddle on the use of precision approach in monogenic diabetes, put forth a consensus report. In fact, they actually formed an interest group in precision medicine known as the PMID, and they decided to look into the various aspects by which precision approach can be utilized in the diagnosis, prevention, and management of diabetes. And this has led to a number of papers in the subsequent years. This was published in 2022. This is a position and vision statement. And again, more recently, there is a consensus report which was published in Nature Medicine, which looks not only on the opportunities of precision medicine, but also on the gaps and probable drawbacks of using the precision approach in clinical practice. So I'll be talking briefly about how precision approaches can be utilized in pre-diabetes, type 1 diabetes, type 2 diabetes, and most importantly, in the monogenic forms of diabetes, which are considered the poster child of precision diabetes. So how does the precision approach apply to individuals with pre-diabetes? Now we know, like people with diabetes, people with pre-diabetes are also not alike. And the simplest way of subclassifying pre-diabetes is to classify them into those with impaired glucose tolerance and those with impaired fasting glucose. And these two types of pre-diabetes differ from each other in pathophysiology, natural history, and response to intervention. IGT. IGT is the most common form of pre-diabetes everywhere in the world except in our part of the world. In Southeast Asia, the prevalence of IGT is much lower than that of IFG. And the pathophysiology in IGT is mainly on account of reduced sensitivity to insulin in the skeletal muscle. The hepatic insulin sensitivity remains unchanged, or if at all, only slightly reduced. There is a defect in both the first and second phase of insulin secretion. And this leads to the typical phenotype of relatively normal fasting glucose, but elevated post-load or postprandial glucose levels. And these are the chaps who have high risk of progression to type 2D, and these are the individuals who have been included in clinical trials of diabetes prevention like the DPP and the DPS. All of them have included predominantly individuals with IGT. And these are the people who respond to those interventions like weight loss, 4 to 7% weight loss, calorie restriction, exercise, and so on and so forth. People with IFG, on the other hand, they are most frequently found in Southeast Asia. Southeast Asia has the highest prevalence of IFG. Here the defect mainly lies in hepatic insulin sensitivity. The skeletal muscle insulin resistance is not affected at all, and is the first phase insulin secretion that is affected, the second phase is unaffected. These individuals have a slightly lower risk of progression to type 2 diabetes, but in those who are going to progress to type 2 diabetes, none of the interventions which were recommended by the DPP or the DPS or the Daching study seem to be particularly effective. So this is very important because in the Western countries at least, there is a movement nowadays towards not doing a GTT to diagnose either diabetes or pre-diabetes. If you do not do a GTT, you do not pick up impaired glucose tolerance. You cannot pick up IGT using a postprandial glucose levels. And if you pick up people with pre-diabetes using a fasting glucose or an HbA1c and you apply the interventions which are based on the DPP, I'm sorry, you are not following evidence-based medicine. Because there is no evidence that these work in people who are not having the classical IGT. I'm not saying that you should not recommend lifestyle modification because it has got a lot of benefits otherwise. But for prevention of diabetes, prevention of cardiovascular disease, whether they'll be as effective in IFG as in IGT, we really do not know. Putting that further, this is a recent Central European study which showed that individuals with high risk of diabetes can be divided into clusters, just like we have clusters for diabetes. And they have divided these individuals into 6 clusters, 3 of whom have high risk of progressing to diabetes. The cluster 3 and the cluster 5 have got extremely high risk of progressing to diabetes, one of whom is characterized by high genetic risk and low insulin secretion, the other by high liver fat and high levels of insulin resistance. And the third cluster, that is cluster 6, is associated with high visceral fat. There, the risk of progression to diabetes is not as high as for cluster 3 and cluster 5, but they have increased risk of developing nephropathy as well as higher mortality risk. So this is an emerging field and expect more developments in the future. Now, what about type 2 diabetes? We are all aware of this study from Leaf Group's team in Sweden, in which he has divided European individuals with diagnosed type 2 diabetes into 5 clusters based on phenotypic variables. And these clusters include 3 severe forms and 2 mild forms. The severe forms, the first form is probably type 1 who was misdiagnosed. And there are 2 severe forms, one associated with insulin deficiency and the other with insulin resistance. And 2 mild forms, one associated with obesity and the other with age. We have tried to replicate in Asian Indians, and we found that while the severe insulin deficient and the mild age-related diabetes remain more or less the same as in the European population, the other 2 clusters were not present. And instead, we had 2 novel clusters, one of which was associated with insulin resistance and obesity, and the 4th group, which are the worst of both worlds, they had low insulin secretion plus high insulin resistance. So these are the 2 novel clusters. And what's the significance of this subtyping? The subtypes differ in the ease of attaining glycemic control. The insulin deficient subtypes tend to find it more difficult to attain glycemic goals. The risk of complications may vary by subtype. Insulin deficient clusters seem to have higher risk of retinopathy, whereas insulin resistant subtypes are more prone to diabetic kidney disease. And there is some evidence now from various populations to show that they may respond differentially to anti-diabetic therapy, and lots of work is going on in different parts of the world, including in India, to see whether this is actually true or not. But even before the results of those trials come, we are already following a precision approach. On the left-hand side, you see the 2017 ADA-ESD algorithm for managing type 2 diabetes. Here you can see for everybody in 2017, every individual newly diagnosed with type 2 diabetes was to be prescribed metformin, along with lifestyle modification, only metformin. Then come all the second line, third line agents. But see what has happened now. We have a precision approach. If somebody with type 2 diabetes has ASCVD, has renal disease or has heart failure, we now have specific groups of agents which have to be given to them as preference over and above metformin. What we don't have a precision approach for is after the first line, what do we give them? That is where we do not have a precision approach. So it's already reached the clinic. All we need is some more fine tuning. Type 1 diabetes, again, not much of work has been done on the precision approach. All type 1s, again, are not the same. They may vary in the number of antibodies, the sequence of appearance of autoantibodies, and so on and so forth, and whether they have residual C-peptide or they do not, which may decide their clinical course. But until now, this is just semantics, because what could you offer them? Even you subdivide them, it is just like a sword of Damocles hanging over them. You could not give them any intervention. But now, recently, there are some treatments which are available for various stages of type 1 diabetes, which can prevent their progression to the next stage. And these include the monoclonal antibody teplizumab, which is recommended both in stage 2 as well as early stage 3. Then we have the Janus kinase inhibitor baricitinib, an oral treatment, which is recommended for stage 3. And verapamil, the calcium channel blocker, which is recommended in stage 3, has been approved. Again, we need to characterize our patients better before we start these treatments, because many of them are very expensive. They are not free of side effects. So we need to give them in patients who are likely to respond best to them. Final 3 minutes, I'll talk about monogenic diabetes, which is the poster child of persistent diabetes. These are forms of diabetes due to defects in single genes. And some of these clinical phenotypes making a genetic diagnosis makes a big difference to the patient. For example, if you have neonatal diabetes, which is diabetes diagnosed below the age of 6 months, it is likely that they have some defects in the genes encoding the potassium channel, the ATP-sensitive potassium channel, and some of them may respond to oral sulfonylureas. It is life-changing for the patient. Similarly, some forms of transcription factor monogenic diabetes like MODY1 or MODY3, they also respond to sulfonylureas at much lower doses. You have the glucokinase monogenic diabetes where you don't need any treatment. You can stop the treatment and just put them on lifestyle. There are certain syndromic forms where making a genetic diagnosis is more important for prognostication and genetic counseling rather than for treatment. Now, these are a few cases from Chennai in whom we have tried to switch over from insulin to sulfonylurea. They're all infants below the age of 6 months, and you can see the sort of decrease in HbA1c which are found in these patients, 14 to 7, 16 to 6. This is the power of precision diabetes. This sort of reduction you cannot get in any other form of diabetes. So make the correct diagnosis, give the correct treatment, you will get the sort of improvement which you can never expect otherwise. And this improvement is maintained over several years. This is data from our center. Up to 3-4 years we have maintained both in KCNJ11 as well as in ABCC8 mutations. And we have evidence from Dr. Hattersley's group in which he has shown that response to sulfonylurea in neonatal diabetes is maintained over a period of 11 to 13 years, which is unlike type 2 diabetes where sulfonylureas are not a very durable form of treatment. And this is what happens when you do not follow precision treatment. This is again one of Dr. Hattersley's patients who was not very happy with sulfonylurea, not because of sugar, but because she felt she was gaining weight. And so somehow she convinced her doctor to switch her over to metformin and see what has happened. The HbA1c, which was around 5.5, for the next 3 years, hovered between 8 and 11% until Weiser counsel prevailed. She was put back on sulfonylurea and the HbA1c went down equally fast. And it's also important to make the diagnosis as early as possible, because the success of sulfonylurea therapy in transcription factor MODY and to an extent in neonatal diabetes depends on the age at which or the duration of diabetes with which you have made the diagnosis and the amount of hyperglycemia that you have accumulated. Suppose you wait for years and years and years before you make a diagnosis, patient has been totally uncontrolled all this while. Even if you switch them over to sulfonylurea at that time, you may not get the sort of response that you expect, because already the beta cell has been exposed to high levels of glucose, it has developed glucotoxicity, it has developed beta cell exhaustion. Therefore, as far as possible, make the genetic diagnosis early and make the treatment switch as early as possible. So I'll conclude by saying that precision approach has now reached a diabetes clinic, and as of now, the precision approach mainly applies to the monogenic forms of diabetes, wherein you have the classical example of improvements in patient outcomes which applying molecular diagnosis. You make the diagnosis, make a change in the treatment, the patient gets the benefit. Unfortunately, as of now, its application in other forms of diabetes is aspirational. That means we wish we had better forms, better ways of more precisely classifying and treating our patients, but we are getting there. In another decade or so, we would expect that there will be more refined ways of finding out what sort of patient has the disease, what disease which patient has, and tailor the treatment accordingly. But the important thing, and from the Indian scenario, which I think is very important, is that all these approaches should not increase the treatment cost to the patient. If it comes to a state where you cannot treat diabetes without doing a genetic test or without doing HOMA-IR or C-peptide in everybody who comes to you, then I think the whole purpose of doing this precision medicine is wasted. We need to have more simpler clinical tools, age at diagnosis, BMI, which we do in all our patients at the first visit. We can find out some algorithm by which we can subdivide our patients using these simple clinical tools. I think we would be able to make the best use of precision medicine. Thank you for your attention.
One day or other, you have to do a screening for diabetes so that you can diagnose early diagnosis and plan future treatment plan. Thank you, sir. Thank you so much. The questions will be at the end, sir. Thank you.
So I think we are moving to the final talk on an important topic, anemia and diabetes. So it is estimated nearly 1 out of 5 diabetic patients have anemia. And importantly, the anemia that has been associated with not only with retinopathy and nephropathy and also with macrovascular complications. So, in order to highlight the aspects of anemia associated with diabetes, we request Dr. Balaji Jagan Mohan to take up the dais. Over to you, sir.
Thank you, Chairperson. So at the outset, I'd like to thank the organizers for having had invited me. So like the chairpersons have said, this is an important topic. In fact, these two conditions, they often coexist. And many a times we are overlooking this condition because we are more interested in the micro and the macrovascular complications. But in the due course of my presentation, I'll try to show you some slides where it is important to recognize and manage anemia, especially iron deficiency anemia and anemia of chronic kidney disease, which is highly prevalent in diabetic patients. So we are all aware of that anemia is extremely common, and it is a very common presentation in most diabetic patients, especially those who have renal disease. Now, if the patient has diabetic nephropathy, then that automatically, it influences the production of erythropoietin, and that in turn can increase the risk of anemia. And it is seen that almost 40% of diabetic patients who have diabetic kidney disease, in them anemia of chronic kidney disease is highly prevalent with low hemoglobin levels. Now, if you take a look at the prevalence of anemia, so globally, it is believed that whether type 1 or type 2, it can be anywhere between 14 to around 45%. And in India, if you see the Indian data, the prevalence of anemia can be as high as 18%. Now, the risk of anemia in diabetic patients is 2 to 3 times higher as compared to non-diabetics. And like I said, anemia of chronic kidney disease is one of the most important risk factors for developing anemia in diabetic patients. Now, these are all some of the most common etiologies for developing anemia in diabetics. Hyperglycemia itself is a risk factor, diabetic neuropathy, oxidative stress and endothelial dysfunction, and iron deficiency anemia, wherein the lifespan of the RBCs can be prolonged. That itself is a risk factor. Certain drugs, metformin, ACE inhibitors, ARBs, even B12 deficiency is another risk factor. What about DPP4 inhibitor use? There are some questions. Pioglitazone, it can cause dilutional anemia, testosterone deficiency, and advanced glycated. So these are all some of the etiologies that have been linked to anemia in diabetic patients. Also, what is known is that if you have diabetic kidney disease, the more severe the disease, so stage 3B and below, the more severe the anemia. So you can see here both males and females. In fact, females have a higher prevalence to have more severe anemia if the eGFR is less than 30. If you go into ESRD, the anemia can be more common. Gestational diabetes, so GDM is another state wherein anemia is very common, and a recent study in 2023 reported that moderate anemia is highly prevalent in GDM patients as compared to those pregnant women without GDM. So we know that a lot of iron-rich foods, a lot of iron-rich supplements are commonly given in GDM patients. So GDM is another condition you have to look for anemia. Now also it is seen that if you have anemia which is more severe, then the risk of vascular diseases, whether micro or macro, can be on the higher side. So here they have staged them as anemia 1 and 2. So if the hemoglobin is less than 11, then there is a higher prevalence of both micro and macrovascular disease. What are the other factors that predict cardiovascular disease in patients with diabetes and chronic kidney disease with anemia? So increasing age itself, if you have heart failure, that's another risk that predicts cardiovascular events. If you have any degree of nephropathy, especially from the microalbuminuric stage, and also NT-proBNP. High NT-proBNP is a marker for higher cardiovascular events in patients with diabetes, chronic kidney disease, and anemia. There are also some angiogenic factors that are implicated in anemic patients with type 2 diabetes. Now, all of them, the growth factors, are common in anemia and diabetes, except for the hepatocyte growth factor, which will be depressed in anemic patients, and it will be slightly high in type 2 diabetics. I'll quickly just take a look at the pathophysiology of anemia and chronic kidney disease. So you can see here, when you have chronic kidney disease, on one hand you have a heightened inflammation, on the other hand you have an increased uremic toxins. So inflammation itself will try to reduce the erythropoietin synthesis in the kidney. There is erythropoietin resistance, and there is this very important substance called hepcidin. Hepcidin, which is released from the hepatocyte, normally would reduce the absorption of iron. But here in CKD, there's an increased level of hepcidin. Hepcidin itself will try and inhibit the absorption of iron from the intestine. So that can lead to a reduced survival of the RBCs and eventually anemia. And also the ferritin, the stored form of iron, will come down as these hepcidin levels will increase. And of course, at the level of the bone marrow, because you do not have stimulation from erythropoietin, so erythropoiesis comes down, and uremic toxin further heightens this. And if you have iron deficiency anemia along with blood loss, then this is further compounded, and all this can increase the risk of anemia in CKD patients. What about the mechanism of anemia, especially in iron deficiency anemia and type 2 diabetes? So we know that in type 2 diabetes, apart from the metabolic aberrations, you also have a heightened inflammation. So a lot of these pro-inflammatory cytokines are increased, including the interleukins and the tumor necrosis factor. And on the other hand, the angiogenic factors, which I've already discussed. All this will put a strain on the erythropoietin synthesis. Hepcidin again goes up. But here in iron deficiency anemia, the red cells happen to survive. So the lifespan of the red cells is increased and the turnover decreases. So basically you can have false positives. If you do an HbA1c, it might be falsely elevated in patients with iron deficiency anemia and diabetes. Hemoglobinopathy. So hemoglobinopathy is especially the sickle cell trait with this hemoglobin S variant has shown from many studies that it can interfere with the HbA1c levels. You can have falsely depressed levels. So hemoglobinopathies, which is very common, carrying the sickle cell trait, we'll have to be watchful about, and the differences that we get in the HbA1c. Iron deficiency, like I said, highly prevalent in diabetic patients. So there are multiple mechanisms, including a suboptimal intake, reduced absorption, malabsorption, blood loss due to diabetic enteropathy like gastroparesis. All this can increase the risk of iron deficiency anemia. And like I said here, the red blood cells happen to survive for a longer period. And when hepcidin is high, automatically it will reduce the absorption of the iron from the intestine. So if you take a look at the glycemic parameters in iron deficiency anemia, you will have slightly high A1Cs. So you will have to do other tests which will help you to give the right treatment, because you might think the patient's A1C is on the higher side. So here 7.2 versus 6.8, in some cases it might be much higher. Also the glycemic variability and the time below range might have fluctuations in patients who have iron deficiency anemia and diabetes. So falsely elevated, again, it's the iron deficiency anemia here. The red cell turnover is reduced and the survival or the lifespan of the RBCs are on the higher side. Also B12 and folate, megaloblastic anemia can increase the lifespan and it might give you falsely positive HbA1c levels. Now what do you do in such a situation when you have falsely elevated A1Cs? You have alternatives. So you have serum fructosamine, you have glycated albumin, 1,5-anhydroglucitol, and you also have the CGMs, which I think all of us are very commonly using. Fructosamine is an average of your blood sugars for the last 2 to 3 weeks, and it's a non-enzymatic glycation of albumin to the hemoglobin, to the glucose to albumin. Whereas 1,5-anhydroglucitol, it's basically the renal reabsorption of glucose that happens. But there might be conditions where it will be most useful, so especially when you have these false positives or end-stage renal disease, wherever you want to see postprandial hypoglycemia. But there might be unreliable results as well, especially if you have liver disease, hypoproteinemia, renal failure. So these are some conditions you have to be watchful. And CGMs, in pregnancy, If you want to use a CGMS, if they're taking acetaminophen or ascorbic acid, then the interstitial fluid glucose levels will be affected. Management of anemia, if it is iron deficiency anemia, it can be oral or intravenous replacement of iron. And we know that there are several ferrous supplements that are available in various salts, gluconate, fumarates, sulfate, but all of them have around 300 to 325 milligram, which is given twice, thrice a day to elevate the hemoglobin levels. And then of course in anemia of chronic kidney disease, you will have to give erythropoietin or darbepoietin. So generally we give 10,000 units weekly once, or darbepoietin between 20 to 40 mg per week. And then based on the hemoglobin levels, you can increase it. And it is seen that these can increase hemoglobin by around 1 to 2 gram per deciliter. These are all the list of iron preparations that are available. So like I said, the salt might differ, but all of them are equivalent to around 200 milligram of elemental iron. And then for B12 and folic acid, you can give up to 2000 microgram per day or 5 milligram of folic acid per day. And parenteral iron. So you know that parenteral iron is available as a 10 ml vial, which has around 500 milligram of iron, and that has to be mixed with normal saline. So basically 1 ml will have 1 milligram, which can be given over 15 minutes as an IV infusion. And the total dose that you can give IV in, iron is around 1000 milligram. You should not exceed than that. So, and of course the erythropoietin stimulating agents, like I said, erythropoietin, darbepoietin, you can start with 10,000 IU per week, and then depending on the hemoglobin levels, you can adjust the doses. Now lastly, I'll just talk about this algorithm for diagnosing and managing anemia in diabetics. So first of all, you do a hemoglobin workup, and if you see it is less than 13 in men, or less than 12 in non-pregnant women, or less than 11 in pregnant women, then you will try to evaluate for the coexisting medical conditions. Review the CBC. If the mean corpuscular volume is more than 100, then you might conclude that it's a vitamin B12 or folate deficiency, which can be due to malabsorption, intestinal disorders, and then accordingly you will supplement with B12 and folic acid. If the mean corpuscular volume is normal or it is low, less than 100, and then you might have to get a serum ferritin and a transferrin saturation. So if the transferrin saturation is less than 20 and the ferritin is less than 30, it's more or less an iron deficiency anemia, and like I said, oral or intravenous iron. But if the TSAT is less than 20, and if the serum ferritin is between 30 to 100, then it could be iron deficiency anemia, or it can be anemia of chronic kidney disease. And then accordingly, you'll have to supplement with the erythropoietin stimulating agents along with iron supplements. So this is, in a nutshell, an algorithm for managing anemia, diagnosing and managing anemia in patients with diabetes. So this is my last slide. So I'd like to conclude that diabetic patients are highly prone to anemia, especially if they have chronic kidney disease or iron deficiency anemia, which is commonly seen in diabetic patients. For iron deficiency anemia, we have oral or intravenous preparations. Erythropoietin stimulating agents are very useful in diabetic patients with kidney disease, especially with higher stages of kidney disease. And I've already shown you the various scenarios where they can be falsely elevated or falsely depressed the hemoglobin S variant. And you might have to look at alternatives in these scenarios. Best would be a serum fructosamine or a glycated albumin, or if the patient is affordable, you can look at CGMS as well. And patients receiving any treatment for anemia, they should be monitored for any of the diabetes-related micro and macrovascular complications. Thank you for a patient hearing.
So before Professor Madhavan conclude, so I just want to express my gratitude to the organizers, so especially Dr. Vijay Vishwanath, Dr. Moses, Dr. Shanmugam, and also Dr. Shanmugam, Dr. Chandrasekhar, and all of the team members for giving this wonderful opportunity. So we personally enjoy the academic fees for this past 2 days. So thank you very much, and it is over to you, to Professor Madhavan, to conclude this session.
Thank you, sir. We had very interesting topics in this session. autonomic neuropathy, one of the complications which is very often not investigated, not the importance needed to autonomic neuropathy is not given very often. In most of the conferences also we don't discuss autonomic neuropathy. I should really congratulate the organizers for including autonomic neuropathy, because many of the youngsters may not know the importance of autonomic neuropathy. It can virtually affect every organ from head to foot. It can affect the brain, the gastrointestinal tract, the eyes, the sexual dysfunction. One of the most important, the speaker did mention about the so-called secretive complication of diabetes. Very often the patient doesn't come out unless you ask about it. It's the most distressing complication for any patient, either erectile dysfunction or retrograde ejaculation. We even now recognize sexual dysfunction in women now. So autonomic neuropathy is very, very important topic, and we had a very excellent lecture from the speaker. Of course, Dr. Unnikishan, as usual, at his best for precision medicine, which is something emerging. Of course, as he correctly pointed out, maybe another decade before we are actually able to apply precision medicine in day-to-day clinical practice. And of course, the third topic, anemia, very common in management of diabetes. We very often come across several patients. In fact, many of our patients are anemic, and it is very important that we recognize what is the cause of anemia and correct it. Of course, we can have one or two questions from the audience for all the three speakers. Yes, Dr. Shanmugam.
Yes, to Dr. Balaji Jagan, for you. That is, we prescribe erythropoietin, no doubt at all. The problem is, one is edema. Second thing is accelerated hypertension. That is one. Second thing is patient with congestive heart failure and anemia, giving intravenous ferric carboxy maltose, it improves quality of life as well as it improves the ejection fraction also. What's your experience?
Yes, sir, I completely agree with you. So if you have heart failure patients and if you give ferroxy, carboxy maltose, definitely the ejection fraction also improves in them. So that is one thing, especially if they have heart failure and reduced ejection fraction. In fact, if you see the NT-proBNP, it might come down after administration of this intravenous iron. So that is one. And secondly, erythropoietin also, as you said, in anemic patients when we administer. So there's a good improvement in the heart failure and other parameters for the CKD as well.
Do you think that the SGLT inhibitors, which causes hemo concentration as well as there is an increase in erythropoietin naturally, do you think that will improve your state now in the diabetes?
I don't think so, sir, because if you monitor the hemoglobin, right, in SGLT2 inhibitors, although hematocrit goes up, but do we actually really see an improvement in hemoglobin? I don't think so, unless we try to correct it. So what he's asking is, if you give SGLT2, would it help in the anemic status?
That has been postulated with reference to improvement in cardiovascular events as well as renal output, that is hypoxia-inducible factor and the improvement in erythropoietin, improvement in anemia. But it's a long way. But immediately we need to give ferric carboxy maltose, which definitely alters the quality of life and life expectancy, no doubt at all.
So some of the nephrologists wait for the serum creatinine to go beyond 5 before they start erythropoietin. You believe that you have to wait for the serum creatinine to go above 5, or you take up only the anemia part of it?
Anemia. So we give
Anemia part, because see, that itself is a risk for any CV events. If you wait for the creatinine to go up with the low hemoglobin, that patient is exposed to CV events. So I think we should correct the anemia. From stage 3B itself, the anemia will be very severe, especially in women.
So even with erythropoietin.
And one more query. So what is the dose and what is the duration of this commonly used metformin leads on to the reduction in B12 resulting in megaloblastic anemia? What is the dose and what is the duration?
So you're talking about the metformin dose?
Yes, yes. The duration and the dose and duration of metformin that results in B12 deficit.
I think nobody
Resulting
can
in
predict
megaloblastic.
it, yes, right? It is very individualized. It's very individualized.
So it's a commonly used drug. It's a very commonly used drug. We combine even with insulin.
I think I should make one more point here regarding the carboxy maltose, and one side effect of which is not very commonly recognized: severe hypophosphatemia. Even though it's a very good drug as far as anaphylaxis is concerned, sometimes patient can present. We had a patient whose phosphate went down to 1, and then when I looked at the literature, it is clearly mentioned. So there is no need of monitoring the phosphate in anyone who has been given ferric carboxymaltose. But bear in mind, if somebody comes with features of hypophosphatemia like muscle weakness and pain, you may have to take, it lasts a long time. Now it's been last 2.5, 3 months since we stopped the agent, but still the patient is having hypophosphatemia. It's not improved. It's by some FGF23 mechanism.
Sir, any other questions?
B12, see, I don't know, sir, I don't know your experience, but whenever we check the B12 in our center or in any other lab, we find it's more than 2,000. Many people are more than normal. And everybody is on metformin. Everybody is on metformin. There's no patient of ours who is not on metformin.
So the problem is that every physician in all diabetic patients, every orthopedic surgeon, every neurologist, they prescribe B12 in and out, and at times even 2 preparations containing B12 that is being prescribed. So when you get the test done after about 2 or 3 months of the B12, it comes to 2,000, 1,200, like that.
But
So-
Dr. Unnikrishnan, it is well known that people who are on long-term metformin, oral B12 replacement is not useful. It has to be
So
parenteral.
the point is that if you give the normal dose, what we give in your, let us say, Neurobion photos, that's probably not enough. Because this metformin, what is this, is that it inhibits the calcium-dependent absorption of B12 in the terminal ileum. If you give a supraphysiological dose of oral B12 like 1,000 or 1,500 microgram, then it can enter the epithelial cells by simple diffusion. You may be able to overcome that. So that's the principle of giving 1,500 or 1,000 micrograms of B12 orally.
Sir, in fact, in DJC we had one paper where there was no correlation between metformin and B12 also. There was one paper which we...
That was only one paper. But otherwise in vegetarians, especially in vegetarians, this deficiency is more prevalent.
Do we have to suspend metformin in the presence of sexual dysfunction? Because B12 plays a major role.
No, that I have already shown you in the differential diagnosis if there is B12 deficiency. But if there is diabetes underlying, then that it becomes secondary. So we have to investigate for the autonomic neuropathy in a diabetic patient irrespective of what are the values of the B12.
So thank you very much.
Sir, I have one
Last
question.
to Dr. Unnikrishnan. You spoke very well about precision medicine. One area where as clinicians we are excited to identify which oral agent will be useful in a particular type 2 diabetic patient. Because we know metformin we routinely start, but we know almost a significant percentage of patients do not respond to SGLT. Even SGLT2 inhibitors, it's known that 20% of the patients do not respond to SGLT2 inhibitors. Do you think that we have reached a stage in clinical practice that we can apply precision medicine and identify, because as you said, the cost.
So there have been certain attempts in the UK to try and find out which type of patient, whether obese, non-obese, will respond to. It's called the Mastermind Consortium, where they have all the data from the NHS. They find the answer and then they try to verify it using the information which they have got out of the various drug trials. And what they have shown is that probably pioglitazone or thiazolidine tends to work better in obese females, whereas sulfonylureas tend to work better in non-obese males. That is one thing they have found. And we, at our center, we are trying to do what is known as the aggregate study. See, I showed you the 4 clusters of type 2 diabetes. Keeping the mild diabetes as a control, we are trying to give cluster-specific treatment. For example, severe insulin deficient, we are giving sulfonylurea first. Or in the IROD group, insulin-resistant group, we are giving the SGLT2 first. And in the combined group, we are giving both the secretagogue as well as the sensitizer and seeing whether this approach is superior to a shotgun approach which we are doing now. So once we get that answer result, we may be able to provide more answers.
Thank you very much. I think we'll conclude the session. Thank you, sir.
Thank the chair and the speakers for the wonderful session. Can I ask the chairpersons to please felicitate Dr. Ranjit Unnikrishnan with a memento?